Medicaid is heading for a generational change. Minnesota Hospital Association members got an insider's view of what's happening from the Deputy Commissioner of the Minnesota Department of Human Services at MHA's recent annual meeting. Now you can hear it too. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm Tim Nelson. In this episode, we're bringing you something a little different. A full-length recording of remarks by Minnesota's Medicaid Director, John Connolly. He was one of the featured speakers at the most recent Minnesota Hospital Association annual meeting and addressed one of the most salient topics in healthcare right now, the future of Medicaid and how DHS is preparing to serve Minnesotans who depend on it. MHA President and CEO Rahul Khurana hosted the talk and fielded questions from attendees at the meeting near Brainerd. Here's John Connolly.
Certainly a pleasure to be with you all today. Understand there's, again, a long partnership between DHS and the Hospital Association here in Minnesota, and certainly under my leadership, intend for that to continue with strength and creativity, and a lot of course, I think, difficult and perhaps turbulent times to come, but we will get through them together, and just know that you have a strong partner in us. It's important to say that hospitals and, of course, the staff within them provide life-saving care and a critical public health function for Minnesota and, of course, across the country. And I want you to understand we know the importance of your facilities, your systems, for the people across Minnesota, irrespective of their source of health coverage, but of course, particularly for Minnesota healthcare programs, both Medicaid or medical assistance in Minnesota Care. So just appreciate the work that you do serving families in their times of need, and of course, providing the most critical and urgent care, and serving as trusted partners, of course, as we talk about how we aspire to improve the health and well-being of our communities, not just in times of emergency or for people with complex needs, but for everybody. And we understand that your systems do that every single day. So again, your commitment makes it possible for people in Minnesota to have high quality care that we expect and they deserve. And just am grateful for the leadership of the association here and all of you as we do that together. So I'm here today to provide, my assignment today is to provide an overview of our analysis from DHS and of course the enterprise in the administration, the Walz administration, and to provide our analysis of the impact of HR1 or the Federal Reconciliation Bill on the state's Medicaid program, or medical assistance, or MA as some affectionately call it. Medicaid, of course, is the foundation for healthcare for 1.2 million Minnesotans, a little over 1 in 5, a little less than 1 in 4 in the state. And it's always important for us to remind ourselves, and I say this in almost every public event, that we serve or cover more people than Medicare in this state or any single commercial insurer. So just reminding folks that even if you are not enrolled in MA or Minnesota Care, somebody you know very surely is. And if you're not now, you could be later, certainly in life, because we cover so many births, but also cover many older adults in our state over the age of 65. Medicaid's a lifeline, of course, covering everything from life-saving treatment, but also preventive services. And it covers half of all long-term care costs in our state. It plays a huge role, of course, as I said, in the development of children. Roughly 600,000 kids in Minnesota are covered by the program. And as I mentioned, just a really outsized role, covering more than a third of births in the state, covering prenatal care and preventive screenings as well. And we also note this fact too in a lot of different settings. And I used this one at a recent meeting for the National Association of Medicaid Directors, and a lot of my colleagues said that's a great stat. I'm going to use it, so I'll say it here. But children who have access to Medicaid are more likely not only to enjoy better health outcomes in adulthood, they attend school more regularly, graduate from high school more frequently, go on to college more frequently, and contribute more in taxes as adults than those who lacked coverage as kids. So that's an important contribution of the Medicaid program to our overall well-being, economy, and society. And I want to emphasize that we're learning new things every day, switching back to HR1, about the consequences of the changes in this now law. And our analysis and the work of national organizations and partners here in Minnesota is still evolving. I'm giving you, of course, a snapshot of what we know today and what we know right now. And of course, one of the biggest missing pieces is guidance from CMS, though that is beginning to trickle out here and there, giving us an understanding of how the administration, the federal administration, is interpreting what's now in statute. But of course, there's a lot to come. Many different pieces of this bill over many years to be implemented. And so a lot of fine print, both in terms of regulation, proposed and final rules to come, in addition to sub-regulatory guidance. So stay in close contact with us as that comes out. We will certainly process it together to understand what the impacts will be. So in the next slide, a few things here to note. I'm not sure if we're doing slides, but in any event, in the next part of my comments here, we'll cover some basics that may be familiar to you, but just level setting with respect to the process and the bill itself, or now law. So it passed on July 4th, and so this is still pretty fresh. And just a piece of context with respect to the ongoing and kind of evolving analysis. This is still new. And again, I think national associations in different states are all communicating with each other to understand what's going to happen in their states. So within Minnesota, I'll start with some of the high level numbers. So first, with respect to people in coverage, we anticipate the number of people who will lose coverage over time of the 1.2 million folks in the program. We expect the coverage loss to be upwards of 140,000 people once all of the eligibility changes are implemented from the bill. And this is based on, of course, analysis from the Congressional Budget Office, but our own Minnesota-specific information and estimates, and of course, just the experts within the Department of Human Services, both in finance, but also our data researchers as well. We also expect Minnesota to lose about $1.4 billion in federal funding in the first 4 years of implementation of HR1. And unfortunately, we expect those losses to grow over time. Counties, given that they have the lion's share of the workforce doing eligibility and enrollment work, will face significant new administrative costs as a result of both the work reporting requirement and the more frequent eligibility redeterminations that are required in the law. And we'll get to some more details about that in a minute. As I mentioned before, these impacts are interactive and cumulative, not just for the state and counties, but also for the people. So people who no longer qualify for health coverage as a result of a work reporting requirement potentially could also lose other supports like SNAP, nutrition support, pushing them possibly even further into poverty. Of course, a reminder that people in Medicaid are either at or near poverty. So these ripple effects, of course, are real and worrisome, but we're committed to working with you to keep Minnesotans aware of what's coming, what applies to them and what doesn't. When and how people and partners like you all can stay in contact with us as all of this progresses and gets implemented. So we're all on top of the changes required to maintain coverage and reduce negative impacts for as many people as possible in this state. So talking a little more specifically about the eligibility components. With respect to the enrollment numbers that we expect to go down and the administrative costs that we expect to go up, the legislation requires adults without kids in the program, kids in the household, otherwise known as the expansion group, who gained coverage under the Affordable Care Act, to have to submit paperwork for eligibility every 6 months as opposed to annually currently. We expect this, of course, to increase churn in the program, meaning that people will lose coverage because they can't complete that new paperwork. And demonstrating, of course, that somebody's working potentially 80 hours a month is going to be a difficult assignment. We will do whatever we can at the state to automate or to streamline these processes such that we can reduce burden both on the people going through the process, but also workers processing the paperwork. Of course, mindful of administrative costs for our tribal and county partners. Again, the expansion group will also have the community engagement requirement, or work reporting requirement, as we call it at DHS, of 80 hours per month. Needless to say, this paperwork is going to be a challenge for all, but I'll note that there are many exemptions, of course, to this. So whether or not somebody has a qualifying behavioral health condition, whether they're a caretaker, have a disability, so there are many, many exemptions, and we expect the number of folks who actually aren't working, who are to be sort of impacted by this policy beyond the paperwork in terms of their actual circumstances to be fewer than 10% of the people in the program. I'll note again, just as a point of explanation, we call this a work reporting requirement because because of that fact that the large majority of folks will either have an exemption or are working presently. And a lot of national data research shows that here in Minnesota, the share of people working in our Medicaid program is higher than the national average. It's important to note that this group, also the expansion group, adults without kids, would be subject to fees of up to $35 cost sharing per service. There are exemptions for that as well, behavioral health and primary care, as well as others. FQHCs also exempt. In the long term, people who can't afford early care, of course, end up needing more expensive care. I don't have to explain that to this room. And providers, as a result, will see uncompensated care. And of course, I learned about that from all of you. Again, I say this with humility in front of this room, but that's bad for people, it's bad for providers, and it's bad for our budget. The legislation, HR1, eliminates eligibility for many categories also of lawful immigrants here in Minnesota, reducing their access to coverage, and again, increasing uncompensated care, potentially for many of your systems here in the room. Moving on to the next slide, talking more specifically about providers, since this is a gathering of healthcare providers. Already in effect is the cap or reduction in state-directed payments. And as Raul mentioned at the outset here, we've done a lot of work on one such proposal with preprint before CMS. And of course, this new restriction or reduction or cap applies to expansion states, states that expanded their coverage through the Affordable Care Act. And of course, Minnesota is one. State-directed payments, we understand, are critical for the sustainability of many providers, especially hospitals, and especially those in rural and underserved areas. So we understand how important this is, and we'll continue working with you to address, the needs and the support that hospitals require to provide the essential functions and care that they do. Current Medicaid rules allow states to establish state-directed payments, and I say this with great humility, knowing that many in this room are expert about this. Medicaid rules currently allow states to establish state-directed payments for hospitals, nursing facilities, and academic medical centers up to the average commercial rate, or ACR, as we often call it. And this section of the law limits state-directed payments to Medicare rates. And of course, that's a massive impact on reimbursement for many hospitals. There are also limits on retroactive coverage from 3 months to 1 month for the expansion group and to 2 months for everybody else in the program. And there's financial impact to that as well. We expect that to be a $31 million reduction in federal funding and $9 million in state funding per year for providers. There is a paragraph in my remarks about why this is important, but I'll spare you all because I know you understand that when folks come in uninsured but eligible for Medicaid, and when we're compressing the timeline for which providers can bill backward for needed services, that impacts, of course, the care that people have access to. But of course, for you all, it impacts your ability to bill for those services, even though people have been eligible, just not enrolled. So I just want to say that we hope that given all these impacts, that you and your team stay engaged in all of the opportunities we provide, the forums that we host, and of course that you host, to stay in communication with each other. A lot of this is coming over the next several years, and it will be really imperative for us to stay aligned with each other and learn from each other. So we'll, of course, digest all the fine print as it comes from CMS and talk with you, but we'll need to talk with you all about what you're experiencing, what your concerns are, what your analyses are. So we are skilled and timely in our responses and how we communicate about these things to the broader public. I'll just say a couple of additional things in closing. So naturally, this was an overview of what's coming in the federal bill. And again, I'll say this is what we know today. Some of these numbers and understandings could change. CMS will continue to interpret what's in the statute. And, sometimes their interpretations may not be what we expect. And we'll just continue to kind of digest that as those things come. And I think I just want to leave with first an overarching message and then a couple of updates relative to our work together that are not related to HR1. But the first thing I want to say in closing is that clearly Medicaid funding reductions and new eligibility requirements in HR1 represent a dramatic change for Minnesota. And I would add a negative one in many respects. These shifts will affect healthcare providers and the people who rely on them to provide care when they can't care for themselves and when they are sick. In particular, we are worried about the adults without kids in the home, the expansion group, given that they will face not only new eligibility requirements, multiple eligibility requirements, but also cost sharing. and we worry about delayed treatments and poor health outcomes, as well as uncompensated care for so many providers. So we'll have to stay, again, in contact with each other about how all of that gets implemented and what its impacts will be, or their impacts will be. And then finally, just a couple of key updates for you all outside of HR1, just so you know that we're tracking and engaged here at DHS leadership. But the first is with respect to inpatient hospital rate updates, or Rebase 6, as I've heard we affectionately call it. We're wrapping up the engagement phase with all of our partners on that, and are moving into implementation soon. The team tells me that it includes nearly a 10% inflationary increase and an additional $5 million dedicated to inpatient mental health services, of course, to reflect the cost that you all have, and of course the growing mental health needs among the people that you serve. And then also the interim reconciliation of MERC, or medical education and research costs, those payments. We'll implement the interim reconciliation of MERC payments for services from January 1st to June 30th of this year, very soon. And the process aims to ensure funding aligns with actual claims and utilization data, so an important aim. And we also want to maintain the program's integrity and compliance. So we've proactively, this is an important note, reached out to all impacted hospitals who, with their individual payment calculations and adjustments if that's the case, and if needed, repayment options to help you with your planning. So with those key updates, and of course that summary, I will wrap up my comments here and be glad to take questions, and just want to finish with a note of gratitude for the partnership, and of course, again, the critical work you do for everybody in Minnesota. And again, thank you so much, and I'm happy to take a few questions.
Great. Thank you so much. I have the microphone. I will walk it around. And questions for Deputy Commissioner Connolly.
Yeah, can you repeat the piece on kids on Medicaid, what they can expect, or that they did better? Could you repeat that again?
So we have 600,000 kids in the Medicaid program in Minnesota. I think largely the eligibility requirements in the law apply to adults without kids, so they don't directly apply to children. But we know that there is a broader welcome mat effect when different groups have kind of enhanced eligibility supports, so to speak, like continuous eligibility for kids. We put in place 0 to 6. When we have those kind of policies, we see a broader impact on maybe other members of the household, such that if one group in the household, or one eligibility group, speaking from a kind of technical Medicaid perspective, has coverage, other groups are more likely in the household to have coverage. So that's one thing we worry about, that there would be a reverse welcome mat effect. Even though kids aren't directly affected by the policy, there are associations among those different folks in a household. So I'm not sure if there were other. Oh yeah, I can give you that quotation. Children who have access to Medicaid are more likely to enjoy better health outcomes in adulthood, attend school more regularly, graduate from high school more often, go on to college more often, and contribute more in taxes than adults who lacked coverage as kids. You got it.
The impacts that you've calculated, do you have that available at any more granular level, such as county level, or perfect would be at provider level if you had something like that?
Yes. So I don't know all the different kind of variables you're looking for, but we have a lot of different information about enrollment and financing and things of that nature by county on our website. So the Medicaid Matters website has a toolkit with a lot of those fact sheets, and we continue to refine those resources. And I think we've done a lot of talking with different hospital systems about different impacts in different parts of the state and what it could mean for them. And they're doing their own analyses with the information that we're providing. So we'll continue to work with the association on those resources. Glad to churn out the information we can, of course, given our capacity limits as well. Yeah.
Good morning. I'm Rochelle Schultz. I'm the CEO at Winona Health down in the Southeast. I'm going to add my thanks to Rahul's for the work that you and your team did for the DPP program. There was a lot of behind the scenes work for all of our membership, and we really appreciate the support and getting that in on time. I had a kind of a question around, listening to the sort of impact on the county. I work really closely with our county administrator, and we both have the concerns about everything that's kind of, flowing out and how we might work together. And so Winona County, for example, has 50,000 people. 8,000 people are on Medicaid.
Mhm.
We have one person who processes Medicaid in the county. So, I just do the math and go, well, that's about 250 or 270 applications per day when you double it up and all of that. They don't have the resources, workforce, we don't. I'm just curious because I understand that Minnesota is just one of like maybe 2 states that like we have it, every county does their own versus sort of like a centralized state, and is there any thought about that? Is there any thought to, because I think these people are actually eligible, and our issue is going to be the bottlenecks and getting sort of that rapid turnaround and all of those kinds of things more than it is like we've got all kinds of fraud happening, right? So is there any thought about that? Because I know where the stuckness is going to be in my county.
I have so many things to say. I do. The first is shout out to the Driftless Zone. I grew up in Dubuque, Iowa, so it's a beautiful part of the state. So being from that part of the country generally, just wanted to call out its beauty. So with respect to the states, I think there are 10 or 11 states. Don't quote me on that, but that's what I remember. Just based on what's between my 2 ears right now at this moment, that do it the way we do. And I came most recently from a state that does it this way. So we have some company, and we usually do confer with each other about this particular challenge of coordination with counties. And I think the good news is, I'll get to the good news first, and then I'll get to the challenge. We made a lot of progress during the unwinding, increasing the ex parte renewal rate or auto renewal, within METs. And so I think we've been as high as 86%, though it's come down a tad in recent months to around 80%. So 8 in 10 folks, families, kids, adults without kids, the expansion group in that system. So basically people who aren't older adults and aren't people with disabilities that are in Maxis. So in the MET system, the auto renewal rate is about 8 in 10. So that does save counties a lot of paperwork. So that's one positive outcome of the enhancements we made to information systems during the unwinding. I think it's in the low 50s most recently in Maxis. So not terrible, but still not as good as we'd like to see it. And of course, for those groups, they have asset tests and other, have to show that they have a disability, document that. So there are other, other requirements of them that make their eligibility more complicated. So what we will seek to do, of course, with HR1 implementation is make as much of this ex parte or automated as possible. I don't know what all the answers are, and I think we and other states and CMS are trying to figure out how we do that. Can we, of course, we already ping like federal data sets or deed data. We will try to be creative about, I don't know. And I'm just going to throw out some ideas because we're processing these in real time. If somebody's in an educational program, what are data sets that we could ping and leverage directly to say, yes, we can confidently say that person meets the exemption. So we'll continue to work through that to see how, or other employment related information that will say this person meets the requirement so we can exempt them. So we'll keep working on that. To your point about the broader structural challenge that we have and the struggle that counties have, I think in particular with workforce, I want to accurately reflect their challenges and understand their, I think what they're grappling with. And certainly we are in very close contact with AMC to talk through what we might be able to tweak and do better and how we can rethink some things. So I think it's an open dialogue and it's been really productive and positive. And so we will try to be aspirational and try to meet this moment understanding. We're already dealing with some challenges and we hear regularly from counties about those, but what can we do to prepare for what's coming and just more broadly enhance what we're doing as a state? And I've said this about so many things in recent months to both folks internally within DHS, but broadly. There are a lot of challenges in front of us right now, but hopefully that will motivate some really positive outcomes more broadly such that we'll have broader system improvements on the other side of this. So I appreciate the question. It's a really pressing and important issue for us. So thank you.
Mine is similar to Rochelle's. Again, thank you for the collaboration and your observation about a lot of work to be done. Let's go to the 6-month re-enlistment, re-registration requirement. What do you think the number of folks are in that bin? And granted, it doesn't kick in till the end of next year. Talk a little bit about how we can help you figure out how to do this, because I actually think this might be a significant logistical problem.
So just to make sure that I follow, so you're asking who specifically is going to go through the twice annual redetermination? Yeah. Okay. Yeah. So that's glad to talk more about that one. So that will be the expansion group explicitly in Minnesota. And so I'll get into some techniques there in a second about why that is, because I know there's been a lot of press. And even I said before we fully understand some things, maybe some of my team already understood it, but it took me a minute to catch up, about parents being also kind of included in some of these work requirements. In Minnesota, it is just adults without children, because we didn't expand coverage to them through the Affordable Care Act. They had coverage previously, so in Minnesota, they're not impacted. So that number is 240,000 people roughly in the program, the expansion group, as of our most recent understanding. And I think I don't want to say that we're not concerned about that requirement. We are. I think anytime there's a new requirement placed on eligibility, we will lose people in terms of enrollment. So that is a concern. That one relative to work requirements, though, just being forthright and transparent, will be less of a challenge from a systems perspective to implement. And the good news is, like I said a bit earlier in response to a previous question, we have roughly an 80% auto renewal rate for that group already, which means that they're somewhat protected, or the impacts could be mitigated by those advancements and those improvements we've already made to our systems. But still, if they're going through a process twice a year rather than once, it could, very much impact the enrollment among that group, result in uncompensated care, all the things that I talked about. But we will do our best to make sure not only that we keep our systems kind of as tight and streamlined as possible to keep that auto renewal rate or ex parte rate high, but also do a lot of communicating and community partnership and engagement, amplifying trusted community voices in different communities so that folks get the information they need and can act on it. So does that answer your question?
Yeah, because buried underneath that is a realization that even though people will fall through the cracks and not have whatever, they're still going to show up in our hospitals and clinics. That's the underlying issue.
Mm-hmm. Yep. The one other thing I'm just sorry, Raul, if
go ahead.
I'm interrupting the flow here, but I want to say, and I meant to say this. So on the work reporting requirement piece, though, that one is a much bigger lift on many levels. There are just brand new things that we're going to have to do that we are not outfitted for in our information systems, rather than doubling the frequency of a thing. I think there's going to be a lot of new paper involved there. We've never had work requirements in Medicaid before. So we'll try to learn from SNAP and other programs that have, but that one's going to be, we think, a lot more difficult to implement and a lot more difficult for people to navigate. So to your point about people coming in uninsured, uncompensated care, let's work together to think about how we can do our best with that one to mitigate impact for you all, and of course, most importantly, for people. Yeah.
Good morning, Amy Hart, Cuyuna Regional Medical Center. Thank you for being here. Recently read in the news about a large Medicaid fraud discovery and charges. So there's that balance of fraud and the balance of more regulations or requirements on the healthcare system, let's say for prior authorization or those types of things. So what is the thought process or department to, we want to go after fraud, I would think. We don't want those dollars going where they shouldn't go. We would hope that they would stay in the system. So how can we balance that without putting more burden on people who are doing it legally, let's say, or.
That's a really timely and important question. And we feel that tension every single day. So we are simultaneously stewards of taxpayer dollars and public administrators. And also we went into Medicaid work to provide important services, life-saving services to people who need them and people who have particular complex needs in many cases. So that is what we, I think at DHS get out of bed every morning thinking about, because we have to hold that tension in the work, and I know you do too. So I think the solution, I'll be forthright. So we can't do one without impacting the other. It's just a necessity of the equation. We have to balance it. And I think we are finding very clearly with our investigations and those of law enforcement partners, we are out of balance in certain places. We need more process controls. And I'll say that as a general statement, but I will say we see that in specific places too, right? That is not true, I think, in every part of the program, but we know that there are certain areas where we have more risk than others based on the data analysis that we've really begun to do in earnest in the last several months to look into different benefits where we are hearing tips, because we've historically, as the commissioner said at a hearing on I think it was on the 17th this week, we've historically relied on tips from the community to tell us like something unscrupulous is happening here. We think there's a bad actor at work. And now we're moving toward a more kind of data-based set of investigations where we look at billing trends, outliers, things that really just don't pass the smell test. And we're looking at those things across benefits where we think we have particular risks. So we will try to take an informed data-based approach, follow the data where it leads us, and apply process controls where they're lacking, generally across the program. But I think more, if I can say this in front of this group, surgically, where we think that we have particular risk. So we'll try to be as informed and as careful and thoughtful and intentional about that as we can be, but understand that your initial comments before your question are very well taken. That anytime we add new requirements, there is kind of an administrative piece to that, and we always balance access and helping providers do their essential work with being good stewards of public funds and having the appropriate process controls in place, such that when people know that their tax dollars are funding a program, that they're being put to good use and not being stolen by bad actors. So thank you for the question.
Great, thank you. We'll take one last question to be respectful of your time. I'll go to Josh.
Good morning, Josh Shepard. I work with Line of Health with many of our rural hospitals and across the outer ring of the metro area. But my question, you talked about surgical. I'm thinking about the increased burden our patients are going to have as they maybe come on and off Medicaid with the new requirements, right? And so you've talked a little bit about it, but I'm curious to know, will there be enhanced public reporting or information sharing as they show up in our ER or they show up in the clinic? They think they have insurance, now they don't. How will we work through that process together?
That is a really good question. I would look to you all for your guidance about how we can improve that. Understanding that the retroactive, coverage period is shortened, that there's going to be increased churn with impacts for your payment levels and your ability to get reimbursed for services. I think one of the things that we know, so there are, I don't want to oversimplify, but the way I think about it with my teams is that part of preparing for the eligibility requirements of HR1 is one part, and apologies for not using the remote to the team here that advanced my slides. I realized that I neglected to do that, so thanks for helping me on that. One part of it is really going to be the information systems work to automate as much of this as possible so that you all don't have to confront avoidable uncompensated care situations or to shoulder additional work to get folks enrolled. If our systems can look at data that's out there, that's ambient in the world, to confirm that people don't need to go through this process, we can say, yes, they're working, yes, they're in school, yes, they're exempt because of a disability or they're caretakers. We'll do that to help avoid it in the first place. But the other piece, so that's kind of one set of work streams. And then the other is, again, this communication, community engagement, all of that work. And so we'll have to work with all of you and many others. It will take a very large village to do this as well as we can. So we can learn from, what your concerns are, what your experiences are, challenges, so that we do this as well as we can. And whatever rules, processes, communications, community engagement opportunities we have, we can make them as reflective of the need that you're seeing and your needs as essential providers, such that we're mitigating impact. So I don't know if that got to the heart of your question, but those are my immediate thoughts.
Again, that's Deputy DHS Commissioner and State Medicaid Director John Connolly. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.